Welcome to KDIGO Conversations in Nephrology. This episode, titled The Podocyte Problem, Understanding FSGS, is provided by KDIGO and supported by Travere. Here's your host, Dr. Kirk Campbell.
Hello, and welcome to KDIGO Conversations in Nephrology. I'm Dr. Kirk Campbell, Chief of the Renal Division at the University of Pennsylvania. Joining me today for a discussion on FSGS is distinguished guest, Dr. Alessia Fornoni. Dr. Fornoni is the Director and Chair of the Peggy and Harold Katz Family Drug Discovery Center and Assistant Dean for Research Training and Development at the University of Miami Miller School of Medicine. As a physician-scientist, her work has provided novel and seminal contributions to our understanding of the pathogenesis of kidney disease. Dr. Fornoni, welcome to the podcast.
Thank you, Dr. Campbell. It's a pleasure to be here.
Great. So let's begin our discussion with an overview question. How is FSGS defined and classified?
Well, the first things I want to say when we talk about FSGS, Focal and Segmental Glomerulosclerosis, it becomes very clear that the definition of FSGS has been largely based on histological pattern of injury. In fact, we have always relied on the Columbia classification for this disorder, identifying different variants, steep, collapsing, cellular, perihilar, non-otherwise specified variants that respond differently to treatments. But it is exciting that with the new knowledge that we have generated about the disease, we are now ready to look at the classification of FSGS with a more clinical lens. In fact, if we look at the KDIGO classification, we now can better define FSGS as primary, which we know is largely immunologically driven, genetic, with more than 60 genes being identified responsible for this, secondary, or undetermined because we still have room for certain disease that don't fit any of these criteria. Whatever the classification is, whether we classify based on the histological pattern or on the clinical presentation, the key aspect of FSGS is that this is a podocytopathy. This is a disease caused by podocyte injury, and which really is responsible for both the clinical manifestations of the disease, proteinuria and loss of GFR.
Yeah, podocyte injury does seem to be the key unifying feature of FSGS. So how does podocyte injury cause FSGS, and what are some of the signaling mechanisms that are responsible for disease pathogenesis?
So we have got to learn a lot about this with the excellent science done by many investigators in this space. Number one, there's nothing as important as human genetics to confer a cause-effect relationship between a given gene and a disease. And if we look at in the past few years, there have been more than 60 genes that have been associated to mechanism of podocyte injury in FSGS, and many of them confluence on acting cytoskeleton regulation. However, more recently, there's many other pathway targeting calcium, lipids, mitochondria, complement, apolipoproteins that really comes into the picture. And among them, really, angiotensin 2, endothelin 1, that can really act in a systemic, autocrine, paracrine way and really contribute to the injury. And although those pathways were thought to be primarily responsible to just change the hemodynamic, they've actually been demonstrated through precision medicine approach to actually alter also some other pathway that I've considered to be extremely relevant to podocyte injury in the context of FSGS. No? Another very important discovery in what causes podocyte injury in FSGS is this concept that that has been around since the early 90s about the existence of a permeability factors that would actually cause podocyte injury in a subset of patients with primary FSGS. And we've been chasing this factor for many years, didn't know whether this could be a protein, a lipid, or anything else. And it's exciting to see that there start to be some knowledge about a potential autoimmune cause of focal segmental glomerulosclerosis, with a subset of patients presenting with anti-SLE diaphragm antibodies that in some cases have been shown to have a cause-effect relationship with the injury pattern that we see in FSGS.
So with recent drug approval news in this space, a lot of attention is being placed on angiotensin 2 and endothelin 1. How do angiotensin 2 and endothelin 1 signaling cause podocyte injury and FSGS?
Oh, these are two amazing culprits of podocyte injury and mechanism that have been extensively studied experimentally and finally coming to fruition. And one of them, endothelin 1, is a stress response peptide that is made by glomerular cells, including the podocyte. This can act actually in a both autocrine and paracrine manner. And it's very elegant studies have demonstrated this crosstalk between podocyte-derived endothelin 1 and the activation of endothelin receptor A on adjacent endothelial cells, resulting in oxidative stress, endothelial dysfunction, which ultimately lead to the degradation of the glycocalyx, that is really the sensor from endothelial cells of what passes in the bloodstream. And what is interesting is that this modulation of the glycocalyx in this crosstalk by endothelin 1 and endothelin receptor A really further goes back to the podocyte, initiating this vicious self-perpetuating loop of podocyte endothelial back to podocyte crosstalk that ultimately lead to irreversible injury. Angiotensin 2 has been studied for a longer period of time. Angiotensin 2 acts primarily on AT1 receptor on podocyte. And once AT1 is actually activated, there's a variety of signaling pathway that are being activated. And this signaling pathway goes from cytoskeletal remodeling to apoptosis, loss of SLE diaphragm protein, and resulting eventually in proteinuria. And that's actually why this combo makes a lot of sense, because working in tandem with endothelin 1, angiotensin 2 can even induce endothelin 1 and amplify the effect of endothelin 1, which is one of the reasons why targeting both pathway is biologically coherent and it's plausible.
Thanks so much. If you're just tuning in, you're listening to the KDIGO podcast on the podocyte problem, Understanding FSGS. I'm Dr. Kirk Campbell, and I'm speaking with Dr. Alessia Fornoni. So Dr. Fornoni, let's discuss the translational impact of these important perspectives. What clinical features should medical practitioners focus on to determine the extent and potential reversibility of podocyte injury?
There's a couple of very important concepts here that we need to understand. I think proteinuria goes hand to hand with food process effacement, and proteinuria in certain cases can be reversible. And we know that with certain intervention, either the old traditional intervention or the new drugs, including disease-modifying agent, we see reduction of proteinuria, and this is usually accompanied by restoration of food process effacement. The problem comes when this results in podocyte injury. And as we all know, podocytes are terminally differentiated cells. And once we reduce the podocyte number, the ability to restore this is really not too feasible. Which brings us 2 points. Number one, the loss of podocyte as a certain threshold after which the lesion results in glomerulosclerosis and tubular interstitial fibrosis, resulting in loss of glomerular filtration rate. So that podocyte number is really what I think would drive the GFR loss and the progression to end-stage kidney disease, while the food process effacement and the proteinuria are more reflecting of early stage, and those are the stage where we want to intervene, because we want to intervene early in the disease process in a way that the reduction of proteinuria would also result in preservation of podocyte number and prevent that inexorable transformations of the podocyte loss to glomerulosclerosis and to interstitial fibrosis. No? So really early recognition matters, because once we lose the podocyte, once we lose the threshold, the sclerosis is irreversible and the damage continues to accelerate no matter what we do. And this gives us a sense of therapeutic urgency, the need to identify patients early, the need to have the patient on lifelong treatment strategies to reduce the progression of the kidney disease. One of the problems we have that intrinsically to this disorder, the proteinuria or GFR loss are not painful and are often not properly recognized by the patients. And I'm sure it's in the practice of many providers to have patient coming when podocyte injury is already there, when GFR loss is already there. So really actually engaging also other providers in the primary care sector to help us identify those diseases at early stage, I think it's key.
Yeah, we definitely want to identify, make the diagnosis, and start to treat before that point of no return. So do our currently available treatment options effectively address podocyte injury?
We know there's a lot of limitations in the way we approach the treatment of FSGS these days, and this is largely being opinion-based and not necessarily evidence-based. No? So we have been treating FSGS with steroids, with other immunosuppressant, but I have to say we've been swimming a little bit in the dark here. No? Number one, we have been using a lot of immunosuppressive agents, not knowing whether the disease was truly immune-mediated or not knowing whether some of these drugs would work for a direct podocyte repair versus a systemic effect, and really aware that a lot of these drugs cause a very significant side effect, mostly in our pediatric population, but overall in the large population at large affected by FSGS. And what is also clear that these medication we've been utilizing historically, they don't really address the underlying podocyte injury effectively. No? So we don't have a tool to stratify which patients will be responsive to a drug versus another. And therefore, really, natural history studies with precision medicine approach will help us to better understand how to match the right patient to the right drug at the right time. And it's just very exciting to see how many new medications are now becoming available that are more really targeting a given pattern of injury. Think about what we just discussed, no? The endothelin-1 and the angiotensin 2 pathway being so nicely demonstrated to be upregulated with great experimental study supporting a cause-effect relationship between this pathway and the development of proteinuria and loss in GFR. And now the recent approval of medication such as sparsentan, so emerging therapies that are dual endothelin-1 angiotensin 2 antagonists that really tie back to the concept that we can preserve podocyte directly and early in the disease process. So I'm very happy as a prescriber. I think it's great these days to be out there and to have options for our patients other than medication that have been maybe effective in a subset of patients, but also with major safety flags.
Certainly a lot of progress, but a long way to go. So before we close, are there any final messages you'd like to leave with our listeners?
Well, I don't know about all you guys, but I'm extremely excited about being a nephrologist in this era. You know, I've been shaking the hand of my patients for many years, saying, sorry, there's not much more I can do. And really, the tools and medication I had available 20 years ago when I started were very limited. And right now, mostly for those of us working in the glomerular disease space, and today we're talking specifically about focal segmental glomerulosclerosis, it's really an exciting time. We have options. We have options that are biologically plausible and options that make us believe that we may be able to cure the disease or at least prevent a rapid progression to the need for renal replacement therapy. So I hope the audience is excited with me about this time in nephrology. And I really want to thank you for asking me this question.
So I want to thank my guest, Dr. Alessia Fornoni, for joining me. It was great having you on the podcast.
Thank you. It was great to be here.
So I'm Dr. Kirk Campbell. To access this and other episodes in our series, visit kdigo.org/podcast. Thanks for listening.